Hello all. Today we are going to be discussing STEM, question STEM. Let's go over the question very quickly. I'll give you a 2 second time to read it. Then I'll start reading it. There's a 37-year-old male who has developed weakness, nausea, vomiting, intermittent diarrhea, constipation, a weight loss. He reports that he occasionally passes out. Also, he feels that his mouth has become darker. Then we look at the vital signs. The temperature is 98.6, the pulse is 105, blood pressure is 91/65. Physical examination reveals darkening of the skin of the elbows, knees, and buttocks. Lab testing reveals a sodium of 129 milliequivalents per liter, potassium of 5.7 milliequivalents per liter, and glucose of 65 milligram per deciliter. Of which of the following, what is the most likely diagnosis? Now, in such a big question stem, let us look at the key features. Weakness, nausea, vomiting, intermittent diarrhea, and constipation. Then his mouth has become darker. He occasionally passes out. There's darkening of the skin. The blood pressure also is definitely reduced. Sodium 129, potassium 5.7, glucose of 65. What is the most likely diagnosis? So far, what we've come to know is that the patient has hypotension, the patient has hyponatremia, the patient has hyperkalemia, glucose is normal, and there's darkening of the skin. So, in such a stem, when there is hypotension, the patient also has confusion because the patient is occasionally passing out. The patient has nausea, vomiting. So definitely this nausea, vomiting can be attributed to the fact that the patient has a mild hyponatremia. There is weakness that can also be explained by that fact. Now, a very high yield point is his mouth becomes darker, or his elbows, knees, and buttocks become darker. So this is a classical case in which there is increased ACTH. This increased ACTH is in response to the adrenal gland not stimulating enough hormone. So there is adrenal insufficiency. Why is there adrenal insufficiency? Because there is hypotension. So most likely this is a mineralocorticoid deficiency. Now, mineralocorticoid deficiency can be explained by the fact that there is hypotension, there is hyponatremia, and there is hyperkalemia. So, in such a case, since 1 year, this is a chronic adrenal insufficiency. The chronic adrenal insufficiency has resulted in the feedback mechanism getting activated, due to which there is an increased ACTH production. Now, this increased ACTH production, there is a slight biochemistry correlation over here. ACTH produces a compound called POMC. Now, POMC itself resembles, and this has a similar structure to MSH, that is melanocyte stimulating hormone. So the body in response produces an increased amount of ACTH, increased amount of POMC, and POMC has this structure is present in the MSH also. So the body thinks that MSH is being produced. So being a structural analog, the melanocytes get stimulated and there is hyperpigmentation. Since there is hyperpigmentation, this clearly indicates that there is increased ACTH. Now let us look at the options. Option A is tuberculosis. Can it be tuberculosis? Yes, it can be tuberculosis. Why can it be tuberculosis? Because tuberculosis of the adrenal gland can lead to uh, chronic adrenal insufficiency or Addison's disease. Waterhouse-Friderichsen syndrome. No, this is an acute adrenal insufficiency. Since the patient is presenting to us since 1 year, that means it's a chronic insufficiency. But if the patient was coming to us, let's say with an infection, let's say 4 days back, the patient developed an infection in which the patient had a fever, the patient had headache, the patient had signs of purpura all over the body, the patient had hypotension, the patient had hyponatremia, nausea, vomiting, weakness, then this clearly could tell us that Waterhouse-Friderichsen syndrome could be the cause because it is a sort of meningococcemia reaction. Then secondary hypoadrenalism, this will not be the answer because hyponatremia is there and hyperkalemia is there. This clearly indicates that the pathology is there in the adrenal gland itself because the adrenal gland itself is not able to secrete mineralocorticoids. Addison's disease, yes, this is the answer because Addison's disease is chronic adrenal insufficiency. Cushing syndrome. Cushing syndrome won't be the answer. The stem does not indicate any factors of Cushing syndrome. Things which go against Cushing syndrome, almost all of them, but the lab investigation of having a glucose of 65 milligrams per deciliter also goes against it, and there is no other clinical feature which will mimic Cushing syndrome. Cushing syndrome clinical vignette will present to us with a patient on lemon on stick appearance. The arms will be very narrow. He'll have a broad abdomen. He'll have stria on the abdomen, bluish discoloration, alopecia. There can be confusion. Osteoporosis can be there. Then he'll have a moon facies, buffalo hump. All of that is Cushing syndrome. So the answer to this question, the more appropriate answer is Addison's disease. But tuberculosis can be the answer also. Now let's look at the second clinical scenario of this question. What is the most likely mechanism of the disease process? So now in this question, if this was, there are two conditions over here. If the patient is from the developed world or if the patient is from developing countries. If the patient is from the developed world, autoimmune adrenalitis is the most common cause of Addison's disease. Whereas if the patient is from the developing world, then we know infections are more common. Even though we are talking about an epidemiological transition, but still infections are more common. So if the patient is from the developing world, then the answer will be TB. So auto antibodies against ACH, this can be the answer. This is myasthenia gravis. Yes, B is the answer because 21 hydroxylase, 17 hydroxylase, these are enzymes which are required in synthesis of mineralocorticoids. Antibody against endomysial protein, no need. Antibody against CCP, this is seen in RA. Antibody against nuclear cytoplasmic antigen, no. C-ANCA and P-ANCA, these are actually seen in vasculitis, so no need for this. If I added a question to this, let's say, given the previous clinical scenario of the following, and we've talked about the clinical scenario that the patient is from, let's say, India, Bangladesh, Pakistan, uh, Southeast Asian countries, and then the patient has chronic adrenal insufficiency. He came to visit someone in the States, got admitted, had health insurance, which is a big thing. So then what would be the most likely mechanism of the disease process? And I put a question F, that the patient had a TB infection. Is that the more appropriate answer? Yes, that is the more appropriate answer because the patient is from the developing world. Thank you.